If you were going to tell anybody with MS what to consider around risk management, what would you want to tell them
Yeah.
in terms of MS therapy? So they're coming onto a new therapy, etc. And that's a very broad question.
Well, but the key issue is that your immune status should be evaluated and monitored. What all these therapies are doing, they are possibly interfering with immunocompetence.
Yes.
And to better evaluate to what extent they are doing that, you have to know where you started from and how this develops over time. And I think this is what I have shown with one of the slides, de-risking immunotherapy. And there is no zero risk, obviously, but I mean you can de-risk in a way that you're trying to eliminate the blind spots, which means you're checking vaccination status, you're redoing vaccinations in case that is needed, you're testing your immune status, and you're doing this while on therapy. And I think this is what I call immune vigilance.
And how would you say it's best to communicate this kind of stuff to somebody with MS? So when I was listening to your talk, a lot of it went over my head just because I think
patients have some responsibilities for themselves, but
Correct.
They actually definitely should go into hands of people that know what they're dealing with, especially knowing the specific mode of actions. So let's put it, they should have expertise with the immunotherapies, but also with its management and monitoring. And I think this is the two sides of the coin. So self-responsibility of a patient, but also getting in hands of a real expert, you know.
And do you think there could be almost, for myself, I'm doing Lemtrada and having monthly checks, but I'm always fatigued by having the checks, and I don't really care is too strong of a word, but I will get some results.
Yeah.
But because I've had it so many times, I'm fatigued by that. Do you think that could be a possibility within the patients themselves?
Well, this is one of the reasons why, for example, things like IT-based solutions, which I showed in my talk, like what RxMX is providing, a lab check or a blood watch, is a solution, because everybody's getting fatigued. I mean, you're getting, you're just not paying attention. But I mean, it's like, as I said, with a airplane accident, it's just a tiny little thing. If this goes wrong, the consequences can be dramatic.
Yeah.
So you need actually other sorts of safety belts. And I think IT-based solutions that actually are preventative, because it's just a machine that does it, are, I think, a clever solution for the future. Especially with such burdensome monitoring rich therapeutic interventions. I mean, if you do that for 5 years, and so you have to do it 4 years after the last infusion. If you get another one, then you have another 4 years. So that's really, burdensome.
I totally agree, and I think that I love data, and I love thinking about linking up people. For me personally, I know that my GP and my consultant aren't linked, so they will call on a regular bit every month near enough saying my lymphocytes are low.
That's really a pain.
So linking, I don't know solutions, but I think what was said then is brilliant for the patient and for everybody.
It's very innovative, and I can tell you that it is really something that has not just in case of alemtuzumab, which is the best practice case, a future, because I mean you're eliminating this fatigue and you're eliminating the factor of human error and laziness or whatever,
But I also agree with what you said in terms of myself empowering myself and therefore knowing what's going on to an extent.
Correct.
But there's so much going on, and I trust my experts, but still needing to have a general grasp of it.
Yeah.
What are your views in general on having repeated different therapies? Is there research around people doing, for example, Tecfidera, then going on to Lemtrada, then doing... It's
a very, very good question. So I'm meanwhile trying to make a very provocative point that I say, okay, we have something like 15 different therapies.
Yes.
but if you think about what is your goal, so do you need 15 different therapies to achieve this goal? I do think that an MS patient, throughout a complete MS patient career, shouldn't have more than 3 different therapies.
Okay.
Yeah. Because, I mean, you sooner or later have to decide either based on efficacy. Things might be different with tolerability. So if MS is peaceful and well controlled, then, I mean, switches might be just based on tolerability, but that's not the point. But I do think this switching is both bothersome in terms of unpredictable risk accumulation, and you should think from the first therapeutic choice, and with every switch, what can I achieve? And I would say, as a general rule, well, try to keep it with not more than 3 different therapies with one patient. Why not?
Yeah.
It's possible with the armamentarium we have.
Yeah, well, I'm on my 3rd, so that will be hopeful.
That could hopefully be your last.
Yeah, I'm always hopeful, but I also, what's your views on then having no therapy as an option because of the unknowns to an extent? Is that something that?
Yeah, we don't have at the moment any, let's say, reliable combination of markers, clinical MRI, biomarkers, that would really be a possibility to guarantee, or at least make it likely, that without therapy you're running as good as with a therapy. So from all we know is that interference with the, let's say, immunological process as early as you can get is better than doing nothing. Except for some cases, I mean, they might be anecdotal, but we can't fish them out. That's the problem. So given the evidence of the doubt, you have to say, well, rather go in favor of, let's say, preventing long-term disability. So that's my take on it. And I'm rather a risk taker in that regard, because I say most of the complications, not all, but most of the complications are better than a damaged brain.
I totally agree. I was having this conversation today about the risk of using anecdotal evidence rather than data evidence, and how important it is to be data robust, in my view.
Correct.
In any case, on your talk, you were talking a lot about PML as well, and I was wondering is there any link between lesion load, or where the lesions are, and potential PML in the future, if that even makes sense?
If I get your point, I mean, PML lesions develop certainly not exactly there where MS lesions are. And this is I mean, the virus can sit wherever, that's actually something we use sometimes for discriminating, because we're looking whether some lesion has just increased or has taken activation, or is it something completely new. So to this point, PML is different than MS lesion, and it also distinguishes reoccurrence of PML versus reoccurrence of MS, and I think that's what we're using. It's really 2 different diseases.
I may have been mistaken how I was looking at it. In terms of this year and the future of risk management, what do you think are the key areas of where's the research going in at the moment, and what?
I think the research is going into risk matrix assessment. So it's not like one single marker can tell you the complete truth. You have to take a combination of markers to give risk corridors. And that's actually what I think is helpful. So as it has happened for natalizumab and PML, where you have a combination of at least 3, maybe some people take 4 or 5 different items to say, well, your risk is in this category or in this category. And I do think this is what other therapies are also going into the direction. Our let's say contribution to this point is indeed doing a deeper immune profiling, as I said. So I think it's oversimplified to assume that one single molecule can tell you the complete truth about a process that is going on. That's too simplified. I mean, with blood glucose it happened, but but MS is much too complex.
If it was like, I think people, me included, are hoping that it would be simple as that,
Yeah,
and therefore it's easy
absolutely.
to manage. But it is.
It might be a lucky shot, and you have heard, for example, things like neurofilament, but also with neurofilament, which is so hotly discussed since 2 years or so, it's not a marker that will act in isolation and will replace MRI. So it has to complement and help the interpretation in addition to MRI.
Okay.
So it's not like you're replacing something, just having one single marker that tell you the complete truth. MS is too complex for that.
No, of course, it's moving on so much.
Yeah.
My last question is just in terms of what can patients do themselves to help in risk management?
Vigilance, adherence, definitely that is meanwhile also I think common knowledge, healthy lifestyle. But I do think adherence and vigilance also, I mean not over vigilance, but vigilance to any things that are outside of the box of MS is helpful, I would think.